ACS NCCRT, thank you, Aubrey. ACS NCCRT's Blue Star Conversation. My name is Caitlin Sylvester. I'm the Director of Programs and Partnerships for NCCRT. And again, thank you all for joining us today. Before we get started, I quickly wanted to do some quick housekeeping. So because this is a virtual session, please note that the session is being recorded. We're not going to post our discussion portions, just the presentation, but something to keep in mind. I also want to remind you to, because this is a Zoom meeting and not a webcast, we please ask that you mute yourself during the presentation. But to make this as engaging and interactive as possible, please plan to come on camera and off of mute during the breakout sessions. As we're kind of gearing up to get started, we'd love to know who we have in attendance. So please put your name, where you're from, and which organization you represent in the chat. And if you have any technical difficulties, you can message Aubrey, and she'll be able to assist you. And please don't forget at the end of the call to fill out our evaluation. It helps us prepare for next time and make adjustments as needed. So just to give you a little background on our Blue Conversation series, as we were hosting webinars and in-person meetings, we found this need to provide our members and other key partners with more engaging formats to discuss important topics and emerging opportunities. So each Blue Star in the series features a short presentation followed by small and large group discussion among attendees. So it's a great way for everyone not only to hear from our presenters, learn, engage with our strategic priority team chairs, but also learn and engage with other attendees. So as a reminder, this series is only open to NCCRT members as well as CDC grantees. And I want to acknowledge that today we do have a couple invited guests. I know some folks from AMGA are joining us, so welcome. So today we'll get to learn from and engage with our ACS NCCRT
are they done?
Education and Practice Implementation Strategic Priority Team.
Fake?
I like to call it PEPI.
Are they done?
And as a reminder, if everyone can mute themselves. We'll also learn about rates of follow-up colonoscopy following stool-based testing, discuss potential opportunities and challenges, and then we're going to share our top takeaways. So we're excited to hear your thoughts and feedback. So it's important that you're geared up and ready to participate, ready to engage in these discussions. And so again, we encourage you to come off on camera and off of mute following the presentation. I am now excited to introduce you to our PEPI chairs, Dr. Frank Colangelo and Dr. Xavier Yor.
Thank you, Caitlin, for kicking us off. So, we're here to talk about our PEPI strategic priority team, and I'm Frank Colangelo. I'm a primary care doctor internist at the Allegheny Health Network in Pittsburgh, Pennsylvania, and had to co-chair this committee with Xavier, and we're glad that you're here with us this afternoon. And what we wanted to first do, if this is the first time anyone has joined one of these meetings, the charge of this priority team is to identify and share promising implementation strategies by organizations to help clinicians and practice teams improve CRC screening rates. We want to identify and share implementation strategies that organizations have found can increase screening rates. We want to develop project ideas focused on health systems and implementation strategies that can help them. And we want to promote ongoing dialogue among all the members of the priority team. Next slide, please. And the National Colorectal Cancer Roundtable has 3 priority teams areas that they wish us to focus on. They want us to mobilize national community efforts that will lead to health equity in CRC screening. They want us to support on-time screening as soon as eligible and continued participation per the screening recommendations with ongoing screening. And we want to promote timely colonoscopy follow-up after positive or abnormal non-colonoscopy tests. So as you can see, timely colonoscopy following an abnormal CRC screening test is an incredibly important topic, and we're going to discuss greatly today. So, as this strategic priority team, it's important we find success stories and understand the role that different players can play in our healthcare systems to accomplish our goal and to find strategies that we can share amongst each other. And a Blue Star Conversation series like we are doing today has been found to be a great opportunity to engage with NCCRT members CDC grantees, and invited guests to discuss these topics. So I'm very happy today to introduce our speaker, Elizabeth Ciemins, who I've worked with for over 10 years, a close friend. Elizabeth and I have done research together on multiple projects, and one of the most recent things we did together was work on timely follow-up for colonoscopy after a positive stool-based test. So Elizabeth, thank you for joining us today. We're anxious to hear your findings.
All right. Thank you, Frank. Can you hear me okay? I was getting multiple prompts to unmute, mute, unmute, mute. So as Frank said, I'm going to talk about rates of follow-up colonoscopy after positive stool-based tests for colorectal cancer. And this work is, what I'm going to share is based on a recent publication in JAMA Network Open that we did, and I wanted to acknowledge my distinguished co-authors, in particular, Jeff Mole, who led this work and the analysis, and of course, Frank Colangelo, who is an important contributor to this work. And I believe this publication it's open access, so you don't have to pay for it. And I think someone's putting it in the chat, a link, so you can read it if you haven't already. So I'm going to do a quick overview of AMGA for those of you who aren't members or don't know about AMGA, talk about the follow-up rates, some qualitative insights, and summary. So who is AMGA? We're a 501c6 trade association, not-for-profit, and our members are healthcare organizations, so both health systems, multi-specialty medical groups, academic medical centers, and now even a few FQHCs have become members. I know there are a few members on the call, so thank you for joining us. And what we do is primarily, we do things to support our members, our over 400 members. So we advocate for them in a lot of different ways, but really most of our organizations are in that move from volume to value-based care. We do quality improvement efforts around chronic diseases, but also around prevention, like immunizations, and of course, colorectal cancer screening. In fact, we have just kicked off or are kicking off a colorectal cancer best practices learning collaborative. And then we do research, which is my department and where this work comes, but often our research supports our other quality improvement work. And I'll talk a little bit more about that in a minute. We have members in all 50 states, and some of them, we have access to their data in a de-identified way through Optum Labs. That's what the yellow dots are. And this is a sample of our members. Some of the names, some of you may even be on the call and see your name up here. But across our membership of over 400 members, we serve 1 in 3 Americans. So AMGA research, what we do, so it's not sort of the typical research you might think about. We don't do clinical trials and drug trials, but we're really trying to leverage evidence to advance practice. So whether that is integrating evidence into routine care, fostering innovation, whether innovation could be new ways of delivering care, new models, or new technologies, or innovation in terms of things that we're doing in our EHRs, et cetera. And then driving change by looking at data and using data to make decisions and actions, and sharing data across our membership so people can see how they're doing as compared to others. So a little background, I don't think any of this is new to you on this call, but why we did this work, that we know that a positive stool-based test requires follow-up, which is recommended within 6 to 9 months. And the reason it's recommended within 6 to 9 months is there are several studies that have shown that a delay past 9 months of follow-up is associated with greater cancer risk and related complications. And there's no reason to do all these stool-based tests if we're not going to get anyone to follow up. So we really, this follow-up is really necessary if we want to capitalize on the benefits of all this widespread screening. We really have to get those people to follow up when positive. So our research question was, what are the overall rates of follow-up? And then also what factors, patient characteristics are associated with those follow-up rates. And then we also looked at including the COVID pandemic. I'm not going to cover that today due to time, but you can find those results in our paper. So this is the schema of our study. So if you sort of start here right in the middle, we looked at a index screening date. So during this time period, we looked for a person's first stool-based screening test. And then from there, we looked backward 15 months prior to determine what those covariates are. And these are listed up here because we wanted to see if any of these things predicted better or worse follow-up. And then we looked forward for a year to see if they had a follow-up colonoscopy. And then we did something different, which is we did something called a survival analysis where we censored people on their last clinical activity, which means we removed them from the data set because we didn't want someone who had left a health system or who had died to be counted as not receiving something just because we didn't know about it. So we censored and removed them, you know, when the last time we saw that they had some kind of activity. So it's a mixed methods design. So just quickly, it was a retrospective analysis. We used data from Optum Labs, focused on the EHR clinical data, but we also did a sensitivity analysis and looked at the claims data so we could see if there were colonoscopies happening outside of a health system that we were missing. We calculated Kaplan-Meier curves. That's what I was just talking about, which is those curves that censor people as they leave or have no activity, and that determines the probability of receiving a follow-up. Then we did a multivariable Cox proportional hazards regression model just to say that was just how we looked at what was a significant predictor of a patient level covariate like age, sex, et cetera. And then we did semi-structured interviews with 5 healthcare organizations to better understand the data and get insights from actual practicing providers. So our inclusion criteria, our age group was 50 to 75. So during the time, the data that we had was, that was what the USPSTF recommendation was at the time. We know now it is 45, but that was just on the data that we had. They had to have some activity prior, which is just trying to get people who were actively seeking care in a health system. And then we made sure they were from a health system that performed or tracked colonoscopies. So if we found a health system that there was 0 colonoscopies, we just removed them because clearly patients were getting their colonoscopies elsewhere and they were not being tracked in that system. And then we just removed high-risk patients or patients who already had a diagnosis of cancer or had lots of previous tests. So this is the attrition table. I'm not going to read through all of this, but just to tell you that we started with 130,000 patients. And then after we removed the patients that I just discussed from the last slide, we ended up with 32,000 patients in the sample. This is the description of their demographic and clinical characteristics. Pretty standard. Our race, it was a highly white population, 88% were white and 92% were non-Hispanic. And then more than half had commercial insurance. Everything else was pretty balanced, but these are the things that we controlled for to see if any of them predicted better or worse rates of follow-up. So the time to follow-up. So this is our overall result and this is that curve I told you about. So it shows you at what point people were getting follow-up. So over here on the right, you can see that 56% had follow-up within a year. And then if we go to 180 days, it was about 51%, and only 43% received follow-up when we looked at the 90-day mark. And then we also, like I mentioned, did a sensitivity analysis. So we looked at adjudicated claims to see if they actually had received a colonoscopy outside of their health system, and that bumped the rates up about 10%. But still not good, still pretty dismal. And then looking at some of these covariates that I mentioned. So by race, so the line, so it's better to be high. The higher lines are better. So this compares and shows that that Black and Asian patients had significantly lower follow-up rates when compared to white patients, and the rates are over here on the right. And that's as big of a difference as 52% among white patients and 40% among Asian patients. Now, looking at the same thing by insurance type, we often look at insurance type as a proxy for income if we don't have data on income. So the rates were lower, significantly lower when comparing to commercial for those who had Medicare and especially Medicaid, which is the lowest rate here at 38.6% follow-up within 6 months. Then we looked at the type of test. So those who had the multi-target stool DNA test had higher rates of follow-up than those who just had the standard or the 1-year FIT test. And you can see there's a pretty large difference there. And then we looked finally at the Charleston Comorbidity Index. So this is an index that predicts risk of mortality, but it's also a good indicator of severity of illness because it counts comorbidities. So those, it kind of makes sense, this graph, those who had index rating of 0, meaning they had no comorbidities, were most likely to have follow-up. And then as the patient became more severely ill with more comorbidities, they were less likely to have received follow-up, which probably makes intuitive sense. I wanted to share a couple qualitative insights. This will help us with our discussion that's coming next. So the first theme was lack of knowledge about failure to follow up. So every single provider we talked to was surprised at the low follow-up rates. And when we asked each one the question, what do you think the follow-up rate is with your own patients? And almost everybody said, well, 100%, because why wouldn't they follow up if they had a positive test? So there really was a lot of surprise because no one had really seen these data. The second theme, which is probably will be familiar to you, is just the overall theme of patient hesitancy around colonoscopy. So, patients are having a stool-based test because they don't want to have a colonoscopy. So they also don't want to have a follow-up colonoscopy, even after a positive test. And they provided some of the same reasons with uncomfortable with the prep and the procedure. And then the cost was an issue. As you probably know, in 2021, there was a frequently asked questions around the ACA that confirmed that you can't charge somebody as a diagnostic test when they're having a follow-up to a positive test because it's considered part of the screening. So that should have reduced some of the issues around cost. And then the third theme was around trust and communication. And so this need to really talk about the potential to have a follow-up at the time of ordering a test. And that's the biggest facilitator to completing follow-up, is bringing up in the beginning. And as a provider said, as a provider, they trust you and your recommendations. So to summarize some of the facilitators and barriers, facilitators, good integration with the EHR, so you're getting those results. Transparent reporting, only one of the 5 systems was reporting a follow-up at all. So that's why they all thought that it was 100%. They had no idea what the rates were. Ease of referrals, having dedicated staff, that anticipatory guidance that I mentioned. And then barriers are kind of the opposite of these, but not having an integrated GI department, no good communication, or not having a good process. Someone said, I think sharing data is excellent. I wish we were doing it more. So there really was a need to see these data. So in summary, almost half of people are not receiving a follow-up colonoscopy within 6 months. Black or Asian race, Medicare or Medicaid, and a FIT screening test versus the multi-target test. DNA tests were significantly associated with lower follow-up rates. And then after accounting for the patient level factors, there really was significant variability in follow-up rates across healthcare organizations. So there's a lot to be learned from each other. We're hoping we'll accomplish some of that in our best practices learning collaborative, where we'll get to compare, people can talk to those who have higher rates, and we'll learn from each other. And then this low provider awareness of rates, plus this lack of internal tracking, we think due to a lack of quality performance measure. Dr. Colangelo and I have also been working on developing a HEDIS measure for follow-up. So that could be coming in the next year or so. They're working on that. And that is where I will end.